Good afternoon, everyone. I'd like to welcome and introduce Dr. Robert Murphy, Executive Director of the Institute for Global Health and the John Philip Bair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine, who answers your COVID questions each Tuesday and Thursday here on the Institute for Global Health's Facebook page. We invite you to continue to submit your questions via Facebook at NU Institute for Global Health or directly via email at globalhealthinstitute@northwestern.edu. And leading the discussion again today is Katie Berg, who is an intern this summer here with the Institute. So Katie, I now turn it over to you.
Thank you, Kristen, and thank you all for joining us, as well as Dr. Murphy for answering all of our questions. Today, we're going to start out with a very new story. What can you tell us about the new Guillain-Barre syndrome warning from Johnson & Johnson?
Yeah, that was pretty hot news that came out yesterday. Apparently, about 100 people have come down with Guillain-Barre syndrome. And this has been temporarily related to taking the Johnson & Johnson vaccine, not the Moderna or the Pfizer, but the Johnson & Johnson. So, overall, 100 people is not very much out of 12.8 million people who've taken the Johnson & Johnson vaccine. So it's pretty low, but it appears to be concentrated mostly in men. And mostly in men greater than 50 years of age and within 2 weeks of taking the vaccine. Now, remember, the Johnson & Johnson vaccine is just one dose. This has been reported before with the swine flu vaccine many years ago. It's also Guillain-Barre can occur after viral infections, and there are about 4,600 cases per year anyway of Guillain-Barre. So it's a tingling and weakness and an ascending going from the bottom from your feet upward paralysis. It can be quite severe and it can be mild and go away. But it's a serious side effect. So they're going to put a warning, I'm sure, on the Johnson & Johnson vaccine. That's just going to be yet another warning because don't forget, it is also associated with a very rare form of blood clots, mostly in women under 50. So we have women under 50 at higher risk for blood clots, and we have men over 50 at higher risk for Guillain-Barre. The vaccine works, and it is just a single dose. It's not playing that big a role here in the United States because first of all, they came out late in the whole development process. Later, they were the third vaccine. And they had when they had those blood clots, there was a pause put on the distribution that was ultimately lifted after they investigated all the cases. And then they had a manufacturing problem at the Emergent facility in Maryland, and they ended up wasting 75 million doses because they were contaminated. They were also making the AstraZeneca vaccine, and it was mixed up. So anyway, so they've had really some stumbles all along, and this vaccine has some benefits that should not be thrown away. The single dose is its big plus, and it does work. It does not work as well as the Pfizer or Moderna vaccine for preventing symptomatic mild and moderate disease. But as far as hospitalizations and death are concerned, the more severe effects of COVID, it works quite well. So it's another little wrinkle in the whole system there, and people just need to know what risk they are taking when they select which vaccine.
Right. And you do not anticipate another pause for J&J over this announcement?
Well, they're going to be responding. We'll have the full actual report. Plus, now that it's noticed like this, the same thing happened with the blood clots in women, is that, people that may have had a mild case of Guillain-Barre or something, these reports may come forward more frequently, just because now everybody knows that, this is one of the potential side effects. So, but still, we're talking about 100, 0.8 million gone out there. The other thing is, though, this has not been reported with the mRNA vaccines, the Pfizer and Moderna. And there's been, hundreds of millions, 321 million doses of those have gone out. So it is specific for the J&J.
Right. Moving on, what can you tell us about the new Lambda variant?
Yeah, Lambda is a new variant that has popped up. first seen in Peru last August. And it's reported to have a very higher fatality rate and death rate. I mean, death rate, fatality rate is the same thing. Deaths per capita in the world, according to Forbes, and accounts for 81% of the Peruvian cases and 33% of the cases in Chile, and it's been found already in 29 countries. It's just another variant of concern, so we have to watch out for this. Now, it's really difficult to figure out if this Lambda variant is more severe or it's just easier transmitted, or, you know, we don't really know yet about that. So, but it is, you know, a variant of concern. And so there'll be a lot more studies related to this.
Right. We should keep our eyes on that for more information.
Right.
Has there been any new information released regarding any of the neurological symptoms we've seen in those who had severe COVID illness?
So there's a lot of interest in side effects, neurologic side effects to COVID. There's the brain fog that gets reported. People just have trouble concentrating and you know, thinking clearly, and they complain a lot. There's a big neurology clinic here at Northwestern run by Professor Igor Koralnik, who's a specialist in this area. He's also head of the global program on neurology and here at Northwestern in the Institute for Global Health. And, you know, they are evaluating all these people. It's very common. There is some evidence that COVID does, in some people, does infect some of the brain cells. And so there's a pathologic reason why this is happening. Most of these people, you know, they can get treated with some of the neurologic drugs if it gets really severe. And many of these people do get better. But if it happens, they need to seek the attention and care of a really good neurologist who's experienced in this.
Right. And are COVID deaths increasing with the COVID cases that we're seeing here in the US?
I'm sorry, can you say that again, the question?
Are COVID deaths increasing with the increase in COVID cases we're seeing here in the US?
Oh, is the death rate increasing?
Yes.
It's really not decreasing. There's a couple reasons for that. One is that these variants are more transmissible. They're not necessarily more lethal. That's one thing. But the other thing is we know how to take care of COVID now much better than we did before. There's the monoclonal antibody treatments. There's all these anti-inflammatory treatments. You know, there's better treatment. The hospitals are not, in most places, are not so full of cases that they're just overwhelmed and having trouble treating people. Now, this is unfortunately not true in the states with the lowest vaccine rates, like Missouri has reported 91% ICU beds are full, mostly with COVID. And the other thing that's happening in those sick patients is they tend to be younger, because the older people, even in the low vaccine states, the older people do tend to be more vaccinated. So it's people 20s to 50s. You know, it's a devastating disease in some people. So about 10 to 15% of people who get infected, you know, end up in the hospital, and somewhere between 1% and 2% die. So that mortality rate really hasn't changed. So it's the same. So it's really not more lethal. It's just impacting a different population. Almost all of the people in the hospital now are unvaccinated. I mean, it's the numbers are actually quite dramatic. It's like 99%. The numbers have ranged from 95 to 99.3% or something like that. So it's almost all unvaccinated people, almost all preventable, which that really translates to.
Right. Do you think that COVID vaccines may become mandated by law, especially in areas where there is such low vaccination rates?
I don't think there's much, you know, interest in a national or mandate to be put into place. But I think we're already starting to see it in certain situations, like hospital workers. The hospital in Houston, which mandated it made it all the way to the Supreme Court, and it was upheld that they can do that. You know, we do it for other diseases. We screen people for tuberculosis. We mandate they have influenza vaccine every year. And so this will be another mandate. So I see health facility workers most likely are going to, this will be required. The other place, which is mandating vaccines, and of course, there's always some exceptions, are universities. So people returning to the university or starting university in the fall, many of the schools are mandating. You have to have proof of vaccination before you come in. The schools that don't do it, and then they have like outbreaks, it's really very disruptive. Even if the people don't get that sick, they do get ill, and you know they have like a flu-like illness and lose their taste and smell. You know, I mean, they get sick, so I mean, they can get sick. Some of them very mild symptoms, some no symptoms. We in the last semester were, you know, many schools were testing students all the, you know, on some kind of, you know, schedule, like weekly, bi-weekly, you know, daily in some cases, you know, and they were finding all these cases. So, you know, it's very disruptive because those people then have to go into quarantine, and then the people around them also go into quarantine until they get a test approximately a week later that clears them to go back. So all this mechanical movement of people in a place like a university, but this could be the same thing in a factory or any other kind of business. So I think you're going to see mandates at the very local level, and some companies will do it, and some companies and institutions won't do it. I think they're going to leave it up. So far, anyway, it looks like they're going to just leave it up to the states. Remember, the states have the most power here. The federal government doesn't really have a lot of power to mandate health things, except you know, federal transportation. You know, when you're crossing straight lines, that's state lines. That is a federal responsibility. But within a state, the states can kind of do what they want. Even in the low vaccine states, some of the governors, like in Arkansas, are really trying to promote more vaccine use because they see the damage going on and the stress on the healthcare system and the increase in hospitalizations and deaths. So, you know, it's going to play out at the state level and at the local and even regional levels.
That's very good to know. And now moving on to some of our viewer questions. First, we start with, are there any updates on the vaccine boosters, whether they will be necessary or how soon we could see them being given out?
Yeah, well, that was a big story at the end of last week, where Pfizer applied for permission to give a third dose of the vaccine. Citing that the antibody levels, which is just one part of the immune system, were declining in a significant number of people. Don't even really know the real data, but I mean, this is what they reported. And that was immediately walked back by both the CDC and the NIH here in the United States, and Pfizer walked it back too. No reason yet to give a third dose to anybody who's been fully vaccinated. Now, that's the general rule. There have been several reports that we've reported on and other people have reported that in patients who are immunocompromised, cancer patients, organ transplant patients, other immunocompromised patients, that show that many of them don't have antibodies or very low levels of antibodies. Antibodies, we measure them because they're easy to measure, all right? But it is one marker of immunity. And that many of them had no levels, even after they were fully vaccinated. And then many they either had low levels or no levels. And so there were a couple studies that actually gave the third dose, and the people that had low levels had a very nice response. The people that had no level, many of them then responded with the third dose. We've been talking about this for a long time. And like with influenza, we give older people 4 times the regular dose. So there are differences out there with vaccines and, how much you're supposed to take. So I think that the EUA approval that Pfizer will be directed towards those populations. It's already done in Israel. It's already done in other parts of the world. It's already done in France, that if you have an underlying immune condition, you should take a third dose. So, it's happening already around the world and will continue to happen.
Yeah, and piggybacking off of that, a patient with underlying cancer conditions was recommended by their rheumatologist to continue masking and follow recommended CDC guidelines, as well as get a booster shot when it becomes available. But they were wondering if they received the Moderna vaccine initially, could they get the Pfizer booster when it becomes available?
That's a good question. Probably it's not going to make any difference. So, but that's just a guess. This is something that's been studied actually in the United Kingdom and actually even here in the United States, of mix and matching. Like maybe that would be good to get slightly different antibodies, because each vaccine makes a slightly different antibody or induces a slightly different antibody, and maybe having different vaccines would be good. The preliminary data show so far, it looks like efficacy is about the same, but they tend to have slightly more side effects when people that mix and match. In the UK, they did it because they're so short of vaccines and they were having a crisis. So, it was kind of like a necessary thing, and they decided to study it while they were doing it. So, but yeah, so most likely it will be okay, but the final recommendation is not yet available. But we're not recommending boosters for everybody either. So, that'll all come together at some point.
Great. And moving on, there was a viewer who submitted a question. They were wondering more about how the vaccine works, and were a little bit afraid, thinking that, the next variant is always worse than the last one. Is that deadlier? Is that not? I know this is a little similar to what we talked about earlier, but are the COVID variants more deadly than previous strains, or are they just more contagious?
Well, right now we know that they're more contagious. We don't know if they're more deadly. There have been anecdotal reports that, people say, oh, the Lambda is more deadly, the Delta is more deadly, but we really don't. And if you look at the death rates, even though we have a lot of Delta now in the United States, they don't really appear to be going up. So, that remains to be seen and to be studied, but it's more that it's easier to transmit. That's why it takes over in a population. It outcompetes the other variants out there.
Right. Thank you for that follow-up. Next, we have actually a little bit of a follow-up again from someone asking about the ibuprofen allergy. If they specifically had an allergy to polyethylene glycol or polysorbate, which vaccine should they go for?
Yeah. Now, if someone thinks they have an allergy to those 2 ingredients, they really need to be, before they get vaccinated, in the hands of a good allergist. And if they do decide, it's always a risk-benefit ratio. Is it riskier to, get disease, or maybe this is the person that should take the J&J vaccine or the Novavax vaccine that's coming out shortly. So, that's it's too complicated to actually answer in a general format here. But, there are plenty of skilled people that deal with these kind of allergic conditions that these people should be in touch with. That's a pretty rare allergy, but, there are ways around it. And, the good thing about the vaccines is that the vaccine component itself actually is gone pretty quickly. It's not like it would go on, if they had a bad allergic reaction, it wouldn't be going on for months or something like that. It doesn't stay in the body very long. It stimulates the immune system, and then the product itself is, molecular level, it goes away. Great.
So another patient was vaccinated in February, but came down with COVID in April and had mild symptoms. She said she would not have known unless her daughter hadn't tested positive for COVID, and she would have assumed it was a mild cold and gone to work. So before COVID, it was a common practice for a lot of people to go to work, even in a public space with a common cold or just feeling a little off. And she was wondering, how does she decipher what we have historically worked through with what are now, even if mild, symptoms of COVID?
Yeah, no, so the mild symptoms do not distinguish between one infection versus another. And COVID is going to mimic these other respiratory infections, particularly in the vaccinated, because the symptoms are so mild. Remember, none of these vaccines are 100% effective from preventing symptomatic disease. It's more in the order of 90%. So, 1 in 10 is still going to get, some kind of infection, and with or without symptoms. So, if anybody has any symptoms at all, right now, it's so easy to get tested, particularly if you have symptoms. You can buy tests in the pharmacy, over the counter. There's several that are available. Almost every doctor's office and hospital now is capable of doing a test, a higher level molecular test. But, getting tested now is no big issue. Anyone can get tested whenever they want, or including the over-the-counter test, which, especially if you do it a couple of times, is very good. So, anybody with symptoms needs to be tested. They shouldn't just get, no one who's sick should just be going to work or school without getting tested.
Yeah, that's great advice. And lastly, a vaccinated college student is returning to campus, like you mentioned, where vaccines are required. However, their roommate, because of a heart condition, is medically unable to get the vaccine. The vaccinated student has celiac, which is technically an autoimmune disease. And they were wondering, is this a safe rooming combination for both of them? And what steps can be taken to ensure the safety of both students with the rise of COVID variants?
Yeah, there's these complicated situations. So just keep in mind that the vaccinated people are protected. The unvaccinated people, for whatever reason, are not protected. So it's the unvaccinated person that is the most at risk. And so they have to really be careful because, they've got this underlying disease, and getting COVID for them is much worse than any complication from the vaccine. So it's always this mixture and a difficult decision to make in some cases. The good news is, there's going to be more and more vaccines that come out, maybe have fewer side effects. Who knows? We'll see as they come out. Like I mentioned, Novavax coming out very soon. And so it'll be interesting to see what goes on there. But in these kind of situations, there's always going to be some kind of situation like this. And, because people are just different, but it's the unvaccinated person that really is the most at risk.
Great. Thank you for all of that great advice, all the information, and thank you everyone for submitting questions week after week. We really appreciate it. And again, thank you, Dr. Murphy and Kristen.
Thank you.